Hello, Year 2 students, and welcome to part 4 of the Haematological series. Congratulations on making it this far. You're almost at the finish. Today, we will just be going through hematological malignancies. So I'll be talking a bit about hematopoiesis, which is the production of different kinds of blood cells. And once we know what happens normally, then we will go on to talk about what happens when things go wrong. So those are going to be your leukemias, lymphomas, and myeloid diseases. Just before we kind of get started though, one side note, make sure that you learn what kind of cells look like what. I say this because we've had past exam questions where they've essentially given us a blood film and had an arrow pointing to a particular cell and being like, please identify what kind of cell this is. So this is a pretty good diagram in showing you what the cells typically look like. So for example, lymphocytes, these are the ones with the nucleus taking up majority of the room in the cytoplasm compared to a monocyte, which looks very similar. But as you can see, there's a bit more cytoplasm there compared to that of a lymphocyte. If you want to have a look at the granulocytes, so your basophils are the ones with a lot, I guess, like of granules stippled outside. So that's a good way of differentiating it. And then eosinophils, these are the ones that look like a set of headphones. Neutrophils, they look very similar, but with less granules on the outside. So point is, make sure you know what kind of cells look like what, because very high possibility that there will be a question like that. And you don't want to be presented with a blood film and be like, I have no idea what any of this is. So yes, make sure you learn those. So moving on to hematopoiesis. So hematopoiesis means the production of different kinds of blood cells in your body. So what happens is we start off with a multipotent hematopoietic stem cell. And what happens is this then differentiates into either your myeloid cells or your lymphoid cells. And then they go on to produce like myeloid or lymphoid lineages. So your common lymphoid progenitor, this is responsible for producing pretty much your lymphocytes. So it goes on to become a small lymphocyte, produces your T cells, B cells, and B cells then go on to produce your plasma cells, which essentially are responsible for secreting a lot of antibodies. Your lymphoid lineage also goes on to produce a natural killer cell, which pretty much is going to go around and cause apoptosis when they come into like cells that aren't operating the way they should be. And then everything else essentially is produced by your myeloid progenitor cell. So as you can see, it produces your megakaryocytes, which go on to produce your platelets. So the platelets or thrombocytes, they essentially flake off this massive megakaryocytes. Myeloid cells also go on to produce erythrocytes, mast cells, and all of your granulocytes. So basophil, neutrophil, eosinophil, and also monocytes, which go on to produce macrophages. So pretty much everything that's not a lymphocyte or a natural killer cell comes from your myeloid lineage. So now that we know how it generally works, this is what can go wrong. So I've color-coded this in terms of your leukemias, lymphomas, and kind of like myeloid diseases. So in terms of your leukemias, we have your myeloid leukemias, which is your AML and CML, acute myeloid leukemia, and your chronic myeloid leukemias. And then your lymphoid ones, so your acute lymphoid leukemias and your chronic lymphoid leukemias. So as you can see, the acute ones affect the blood cells earlier on versus the chronic ones affect them later on. And then we've got your lymphomas. So those are only going to affect your lymphocytes only being the ones that come off the lymphoid lineage. So you've got like T cell lymphomas, B cell lymphomas. We'll go into that in a little bit more depth later on. And then your multiple myeloma, which is essentially a malignancy affecting your plasma cells. Then everything else, we've got your primary myelofibrosis, which affects your stem cells, your PRV or Polycythemia Rubra Vera, affecting erythrocytes, and essential thrombocytosis, affecting your thrombocytes. So it's quite a lot to take in. We will go into things in a bit more detail later on, but this is a good summary slide to come back to essentially assess your knowledge and make sure you understand how everything ties together. So things can get a bit confusing. So just a bit of a general overview as to what means what. So leukemias refer to there being too many white blood cells. Lymphomas refer to there being too many lymphocytes. So those are kind of two things that people get a bit confused about. So leukemias include everything like all of this. It can be issues with your eosinophils, basophils, neutrophils, as well as your lymphocytes. Lymphomas are only going to affect these like the B cells and the T cells. So multiple myeloma, we said too many B cells, essential thrombocytosis, platelets, polycythemia rubra, Vera, like red, so that's like red blood cells, and primary myelofibrosis. That's when you get fibrosis of the bone marrow. And if you think about it, all of your cells come out of your bone marrow. So fibrosis of this will end up affecting all of your cell lineages, hence affecting all of the cells that come out. So we'll start off by talking a bit about your leukemias and your lymphomas. So kind of to differentiate between the two, the main thing that distinguishes leukemias from lymphomas is where they come from. So leukemias are diseases that arise from the bone marrow versus lymphomas, which arise from the lymph nodes. And if we think about the difference, right? Cells that come from the bone marrow, your bone marrow is responsible for producing these cells. So leukemias, you'll see a lot of immature white blood cells floating around in the blood, versus lymphomas. By the time your blood cells have, or mostly like, I guess, your lymphocytes, like B cells and T cells, by the time that they've migrated to your lymph nodes, they have already matured. So most of the time in lymphomas, you'll see mature lymphocytes versus leukemias, immature white blood cells. There is a bit of like confusion in the sense that, oh, but leukemias, you can also find them in the lymph nodes. That's also because like leukemias, they're a cancer, right? And cancers can metastasize via the lymphatic system. So you'll often get leukemias that have metastasized to the lymph nodes. However, because those cancers originated from the bone marrow, those are still considered to be leukemias rather than lymphomas. It's just a little bit hard to distinguish between the two when the disease has progressed later on. Anyway, so let's talk a bit about leukemia. So leukemias, it's unregulated proliferation of your immature and non-functional leukocytes. So if we have a look at these two blood films here, so normally your blood is made up of a lot of red blood cells, a lot of white blood cells, platelets. There's like a good balance. What happens in leukemia is you end up with a lot of white blood cells. And as you can see, because there's so many white blood cells there in the blood, that kind of crowds out all of the other cells. So you end up getting less red blood cells, less platelets, and less of your other white blood cells. And this is kind of known as crowding, with basically all of your other cells being crowded out because you have so many of your non-functioning leukocytes present. So the clinical manifestations are as you would expect. If you don't have enough red blood cells in the periphery, you're going to have anemia and you're going to have the, I guess, signs and symptoms of anemia. So don't know if you guys have heard this, but it's a SAD-F, so syncope, angina, dyspnea, fatigue. You would also have thrombocytopenia because you don't have enough platelets in the periphery. And you would also actually get leukopenia, and that would result in increased infections. So the question is, well, if I have like abnormal proliferation of white blood cells, why would I be getting more infections? And the idea is your body is producing more white blood cells, but these white blood cells aren't actually functioning. So they're not working the way they usually do. For example, if you have a lot of white blood cells, but only of one type, instead of producing a bunch of different antibodies, your body might only just be producing one type of antibody. And that's not going to be enough to fight off an infection, especially if that antibody isn't for that particular infection. In terms of other stuff, so you'll also get like systemic signs, so your weight loss, fever, night sweats, that kind of stuff is quite characteristic of any malignancy. And also you will expect to see some hepatosplenomegaly, and that's because your liver and your spleen, these are your extramedullary hematopoietic organs. So when your bone marrow doesn't produce or is incapable of producing enough blood cells, your liver and your spleen kind of kick in to action and they go on to produce other things. So because they're working in overdrive, essentially you'll get an enlargement of your liver and an enlargement of your spleen. In terms of like bone pain, that's just because you have a malignancy in your bone marrow. So like your bone pain, that's kind of expected. Lymphadenopathy just depends whether or not the cancer has metastasized to your lymph nodes. That will kind of be a more progressed malignancy rather than early on. So in terms of leukemias, you can have acute versus chronic. Acute, they're usually more aggressive, but they are curable. Chronic, they are asymptomatic, last for a long time, and they tend to be non-curable, but they also don't tend to have as intense symptoms. They're not as aggressive. So in terms of leukemias, there's four main ones that you need to know. So we've got the myeloid and lymphoid leukemias. So your myeloid, you've got your acute and your chronic. For your lymphoid, you've got your acute and chronic. This image over here, this is just taken from faculty. So you can have a look at that in your own time, but I've essentially made a table that summarizes the main things that you need to know for each. So we'll talk about this a bit in detail. It's quite a lot, but once you know this, it's pretty much all you need to know about leukemias. So for your acute leukemias, we've got myeloid and lymphoid. So the differentiating factor is acute myeloid affects older people, acute lymphoid affects younger children, approximately like 2 to 5 years old. One way of remembering it, I guess, is like all kind of like affecting everyone, all people. So children are also included in this category. And because it's an acute leukemia, it's defined as having more than 20% of blasts being your immature blood cells in the bone marrow or the periphery. So for myeloid, it's 20% myeloblasts. For lymphoid, it's 20% lymphoblasts. And the clinical symptoms you'll see are going to be your crowding, so leukopenia, thrombocytopenia, and anemia. And the way we treat it is give very aggressive chemotherapy, because if you're thinking, think about these leukemias, these are very aggressive leukemias. They're going to cause a patient to deteriorate very quickly. So you want to treat this very aggressively. In terms of like favorable prognostic factors, they're not too important. One to kind of remember is like the chromosome 12 and 21, translocation of that. That's a favorable prognostic factor for ALL. And the way to remember it is like kids flip back to health. So it's 12 and 21, numbers are flipped. In terms of buzzwords for Monash exams, or rods, not too sure how to pronounce that. So our rods, you see them for AML, and then ALL will typically be your young pediatric patient. So make sure you kind of know these two and associate them with the corresponding leukemias. For your chronic leukemia, so you've got your CML and CLL. So CML, kind of the same demographic as your AML. What happens is you actually have three phases. So chronic phase, and the phases depend on the percentage of blasts, either in the periphery or in the bone marrow. So your chronic phase is when you have less than 10% of blasts, accelerated, getting a bit worse, 10 to 19%. Blast crisis is more than 20%. And once you get to the blast crisis, it's pretty much like an acute myeloid leukemia picture. So then you would also start giving them aggressive chemotherapy for that. Just in terms of like diagnosis, so people usually get diagnosed in the chronic phase. I believe it's like 80% of all people who end up getting diagnosed. And the way we treat it is actually a bit different. So we don't go and give chemotherapy. And the reason is, unlike the other like leukemias, such as like your acute ones, we actually know what causes your chronic myeloid leukemias. And it's something called your Philadelphia chromosome. So pretty much what happens, you've got two chromosomes, 9 and 22. And what happens in CML is a bit of the 9 and a bit of the 22, they do a swap. So they translocate. And this is your BCR and ABL gene. And what happens is basically it's your tyrosine kinase. And remember, your tyrosine kinase are your on and off switches. So if you turn the tyrosine kinase on, that's going to cause like endless proliferation. And that's essentially what happens in CML. That translocation causes the tyrosine kinase kind of switch to be turned on. So you get a lot of replication of your white blood cells, and that's what causes your CML. So essentially, to treat that, we just give tyrosine kinase inhibitors because that will stop that like switch from turning on. And pretty much most of the patients respond very, very well to it. So one drug to kind of know of, it's called imatinib, otherwise known as Gleevec for the brand name. And if you give them that, it's relatively a good prognosis. So CML, buzzwords, very important to know: Philadelphia chromosome, Philadelphia translocation, BCR, ABL, chromosome 9 and 22 translocation. In terms of what's where, BCR is the gene on chromosome 22, ABL is the one on chromosome 9. Then last one, CLL. This is just really old people, mature B cell kind of malignancy. And it's a pretty good disease to kind of get compared to the rest, in the sense that like people usually die with it rather than die from it. So you usually don't do much for it. You kind of just observe and see like, oh, how is the cancer progressing. If you don't have any symptoms, we'll just kind of leave it. If you do have a bit of symptoms, they'll probably give you a bit of gentle chemotherapy, but that's pretty much it. And buzzwords for that would be your smudge cells on the blood film. So a lot of information to kind of take in. Main things to kind of know is your buzzwords essentially, especially your Philadelphia chromosome. Make sure you know that it's your CML, because 100% there will definitely be a question on the exam on this. In terms of what your our rods, and your smudge cells look like. So our rods, they refer to kind of these rods that you can see inside the cell. And smudge cells, they kind of just look like a cell that's been like smudged across the blood film. So that's CLL, this is your AML. Okay, so next we will be moving on to lymphomas. So lymphomas, these are going to just be your lymphocytes. So non-functional lymphocytes that accumulate in your lymph nodes. So there's two ways to separate lymphomas. The way that we'll talk about is separating it in terms of Hodgkin's lymphoma and non-Hodgkin's lymphoma. So Hodgkin's lymphoma is basically buzzword Reed-Sternberg cells, or owl eyes. I think I've got a picture here. So essentially it looks like an owl. That's the way that you remember it. And non-Hodgkin lymphoma just means that they don't have these Reed-Sternberg cells. Typically speaking, Hodgkin's lymphoma has a better prognosis. A way of remembering that is like owls are cute, so better prognosis. In terms of what you see for signs and symptoms, you'll get your B symptoms, which is fever, night sweats, and weight loss. And you will also tend to see your lymphadenopathy compared to leukemias, which tend not to have that. By the way, this picture is also from faculty, so don't worry, you'll like get all of this in depth explained by them as well. But yes, this is a table that once again I kind of like put together. So Hodgkin's lymphoma versus non-Hodgkin's lymphoma. Make sure you know Reed-Sternberg cells is what differentiates the two of them. In terms of non-Hodgkin's lymphoma, actually quick word on this. So Hodgkin's lymphoma, it's actually like a B cell lymphoma. The only difference is kind of like they've separated it into Hodgkin's and non-Hodgkin's, but B cell lymphomas, they kind of also, so Hodgkin's lymphoma are also like affecting your B cells, just a side note. But for non-Hodgkin's, we can also split it up in terms of like your B cell lymphoma, T cell lymphoma. There's also your natural killer cell lymphoma as well, but it tends to be like a really, really small percentage. So I just haven't included it. In terms of what you need to know, make sure you know Burkitt's lymphoma. That's a non-Hodgkin's one. It falls under the B cell lymphoma category, and it's due to a c-MYC mutation. That's pretty much all you need to know. In terms of antigens, main one that comes up quite frequently is your CD20. CD20 is specific to B cells. So the way that you would treat a B cell lymphoma, you would give a CD20 like an anti-CD20 agent. And the most popular one, or like the one that most commonly is known, is rituximab. Don't really need to know much more in addition to this. If you want to learn the different chemo agents, feel free to, but I don't think it's super, super high yield. Okay, so that's your leukemias and lymphomas. Very quick recap. Leukemias, we've got four main ones: your lymphoid, myeloid, you can categorize them into acute and chronic lymphoid, acute, chronic, myeloid. Make sure you know the buzzwords for each of them. So if I say like our rods, you should immediately tell me that this is going to be AML. Then for lymphomas, we've got two main groups. You've got your Hodgkin's, you've got your non-Hodgkin's. Main thing that differentiates the two of them is going to be your Reed-Sternberg cells. Also a buzzword, make sure you know that. Now we will be moving on to myeloid diseases. So kind of like the rest of the stuff. Main stuff that we'll be covering is all over here. So now we'll talk a bit about your Polycythemia rubra Vera. This is just when you have too many red blood cells being produced, and 95% association with a JAK2 mutation. So the signs and symptoms that you'll often get, you'll have like increased bleeding, increase in thrombotic events, just because as your body's producing more red blood cells, you're also getting more platelets being produced as well. And the buzzword for PRV is going to be pruritus after a hot shower. So if you have a stem, like a 50-year-old man complains of excessive itchiness after hopping out of a hot shower, he's also noticed excessive or like more bleeding than usual, it's probably going to be PRV. In terms of how we diagnose it, there's like your major criteria and your minor criteria. So major is like these three, basically increase in red blood cells, trilineage growth in your bone marrow, and also JAK2 mutation. Minor criteria is decreased EPO levels. which is what you'd expect, because if you have too many red blood cells, you would want to not produce any more. So that's why there's a negative feedback, which dampens down the EPO. In terms of like diagnosing, you need to have like at least, or you either have to have all three of them being met, or you need to have like two of them and also decrease EPO levels. Don't need to know too much of that in second year though. In terms of management, how you would manage PRV, so you basically do a phlebotomy, which is removing blood until your hematocrit is like below 0.45, give them prophylaxis aspirin because of the thrombotic events, and also some cytoreductive therapy such as hydroxyurea. That's one that you tend to see quite often. Essential thrombocytosis, thrombo is like platelets, so overproduction of platelets. Also associated with JAK2 mutation, but this one's only 50% compared to PRV, which is 95%. So main things that you'd expect to see: thrombotic events, and also, strangely enough, spontaneous abortion. So a typical stem might be like 26-year-old female who has had 3 miscarriages in the past 6 months or something, and yeah, is currently complaining of shortness of breath or something. So whilst the immediate thing wouldn't be like ET, that's something to keep in the back of your mind after dealing with like the shortness of breath kind of situation. In terms of treatment, once again, give them aspirin for the thrombotic events and hydroxyurea to target the JAK2 mutation. Oh, by the way, just like with regards to the blood films, these are all your platelets in here. As you can see, there's a lot. Third, primary myelofibrosis. So this is also associated with JAK2 mutations. And pretty much what happens in here is myelofibrosis. So it's kind of fibrosis of your bone marrow. And what you typically will see is teardrop cells. So this is very characteristic for primary myelofibrosis. And a way to remember it or kind of think it through is all of these cells, because your bone marrow is so fibrotic, they have to squeeze out in order to get into the blood. And to squeeze out, that's how they get their teardrop kind of shape. And if you were to do a bone marrow biopsy, you would end up with a dry aspiration because there's essentially no more cells to draw out because your bone marrow is so fibrosed. And other things that you might get, you will see a bit of hepatosplenomegaly. Reason for that is if your bone marrows aren't producing enough cells, your liver and your spleen are going to kick in to try and compensate for that. So hence working overtime and enlarging. And basically for your primary myelofibrosis, you start off in a hyperproliferative state and then go onto a pancytopenic stage. So the reasoning for that, might be you might have some kind of leukemia to start off with. Your bone marrow is producing a lot of cells to the point where it's not doing it properly anymore and it starts to become fibrotic. And as it becomes more and more fibrotic, your bone marrow will no longer be able to produce those cells, and that's why you get a pancytopenic stage. But basically, stuff in red, that's going to be your buzzwords. So far, we've talked about JAK2 mutations. Those are associated with 3 different diseases: your PRV, essential thrombocytosis, and also your primary myelofibrosis. Multiple myeloma, a bit different. So not associated with your JAK2 mutation. This is more just you have uncontrolled proliferation of your plasma cells, and these are the ones that are usually responsible for producing your immunoglobulins or antibodies. And if you have uncontrolled proliferation, you'll essentially end up with one kind of plasma cell being proliferated and hence only have one antibody being produced, which is not good. So signs and symptoms, a good mnemonic is CRAB, hypercalcemia, CRAB like C for calcium. So hypercalcemia, renal failure, anemia, and bony lesions. So typically you'll see Rolex bodies on your blood film. So these are the ones that kind of like roll together, I guess. And yeah, bone marrow, you'll see like a lot of plasma cells. Urine test, not really important. And last one, we've got the Myelodysplastic Syndrome. So this is pretty much when you have an issue with the multipotent stem cell. So as you can imagine, because this is something that happens to the stem cells very early on, this is going to end up affecting all of the cells that are produced later on. So both your myeloid and your lymphoid lineages. So what you'll typically see is a lot of immature blood cells being released into the periphery, and that's just because like it hasn't had that chance to mature. So what you'll typically see, you're going to see anemia because like the red blood cells that are kind of like pumped out aren't functioning properly. So if we give the patient iron, folate, B12, things that usually help resolve the anemia, you're not going to have anything work, and that can give you a bit of an idea as to like what might be going on. You'll see like hyposegmented nuclei, for example, your white blood cells, normally they're going to mature and then have like normal amounts of like nuclei. If they're hyposegmented, it just means they haven't had the chance to mature and they're kind of just blasts in the periphery. And also same thing for your platelets, they haven't had the chance to mature properly either. So typically what we do for it, you kind of just have to treat them symptomatically. So if they have anemia, give them blood transfusions. If they're like low on white blood cells, give them the white blood cells. Otherwise, you just have to give them like a stem cell transplantation. That's kind of the only way to cure the disease because it's affecting your stem cells and affecting the lineages so early on. But apart from that, there's not a lot that you would do for this. You can't really like wipe out all the cells because you have all the cells are just like not functioning properly and they're immature. Yes, so all right, and last one, we've got myelodysplastic syndrome. So myelodysplastic syndrome affects kind of like the stem cells, so the multi-potent cell that you saw at the really top of the hematopoietic kind of like diagram. And what ends up happening is because it affects the stem cell that's so early on, all of your cells produced end up being affected. So it affects both your myeloid and your lymphoid lineages. And what you end up with is immature blood cells being released into the blood. So even though you do have like red blood cells, you have white blood cells, you have platelets still circulating, none of them are really working properly because they're not like mature. So what you'll get is like refractory anemia. So normally your anemia would respond to your iron, folate, or B12. Those tend to resolve the anemia because they tend to be like the problem. But if your anemia doesn't respond to any of these, it's known as refractory anemia, and that's what you see with myelodysplastic syndrome. Same thing with your white blood cells and your platelets. You're going to see like hypersegmented nuclei, large agranular platelets. These are just because they haven't had the chance to properly mature and they're kind of just hanging around in your blood in their immature state. So in terms of what you'll see in a bone marrow kind of like aspiration, it's going to be hypercellular. You're going to have a lot of cells in there, but also they're going to be quite dysplastic. So they're not going to look the way they usually do. And the way you treat it, the only way to really cure the issue is by doing a stem cell transplant because the problem is so early on. And if you are unable to do that, you kind of just have to give them supportive therapy. So if they're anemic, maybe like do a blood transfusion. If they're having a lot of infections or, for example, they're bleeding a lot, then you would transfuse them with platelets. So unfortunately, that's kind of the only way that you really deal with it. But yeah, that's pretty much it. So I know this has been quite long, but hopefully that gives you guys, we won't go through questions, gives you guys a good overview as to the hematological malignancies. So a bit of an overview, we've talked about leukemias, the 4 different types, talked about lymphomas, 2 different types, and then all of your myeloid diseases. The top 3, PRV, ET, and PM, these are associated with your JAK2 mutations, and multiple myeloma, and myelodysplastic syndrome are a bit different, but make sure you kind of know the keywords or buzzwords for all of these. So congratulations on getting through the entire hematological series. Hope you guys kind of enjoyed it or like didn't find it too difficult to understand. If you guys have any questions, as always, feel free to message either me or Stella or chuck them on Curious Cat, and we will be keeping an eye out for those. But otherwise, all the best for the rest of your studies, and yeah, see you next time.